sir is here, so we can start with
So
this.
we can start with
That will
Saxena,
be
sir.
better.
So
Manoj sir is facing some
yes,
difficulty.
yes.
Yeah.
So let's proceed with the second talk because Manoj Gumbar sir is joining. There is some network issue. So it's on minimization, conversion, and toxicity management in CNI use by Dr. Vishal Saxena, sir. Over to you, sir.
Hi, Saurabh. Thank you very much. I hope I'm audible.
Yes, sir. Audible, sir.
Yeah, just give me a time how to share my slides. Uh,
Yes. There is a share button in the middle at the just the bottom, sir. Green colored, fluorescent
yeah,
green.
yeah. I
Yes,
got
sir.
it.
The screen is visible, sir.
Yeah, but
Now,
I'm just trying to find my slides.
yes, sir.
Just give me a second.
Yeah, no problem, sir.
Just a second.
Yes.
Just share this.
Can I just close this?
Oh.
Are you sharing?
Yeah.
Yes, sir. Now, in the presentation mode, sir. Yes.
Good.
Yeah.
Yes.
So, So we'll be talking about minimization, sparing regimes, and toxicity management of CNI. So we all know that calcineurin inhibitors are the foundation of immunosuppression for renal transplantation. CNIs are the cornerstone of immunosuppressants after kidney transplantation, with over 90% of recipients in 2017 maintained on CNI based regimens. Although CNIs are effective, they have extensive toxicity. So, two primary strategies have been used to balance efficacy while limiting toxicity. One is to monitor the levels to guide the dosing and minimize the CNI usage. Alternative immunosuppressive regimens have been designed to reduce or eliminate CNI exposure, and they have been investigated, and four alternative approaches to full dose therapy have emerged. So we all know that how CNI affect the allograft. So by oversuppression or by immunosuppression side effect, so either people can have viral infections like BK virus, CMV, bacterial infections, malignancies, or chronic allograft nephropathy can also happen because of non-adherence, the development of DSAs, CNI-induced hypertension, nephrotoxicity per se, and death from a functioning graft because of cardiovascular disease, hypertension, and metabolic syndrome and post-transplant diabetes mellitus. So people started, according to the transplant center strategy, they started with a fourfold therapy to be in the initial phase. The first was to use an induction agent, either anti-thymocyte globulin or anti-CD25 monoclonal antibody, plus triple drug immunosuppression, which included CNIs, tacrolimus or cyclosporin, steroids, and antimetabolites like mycophenolate mofetil or sodium, plus minus mTOR inhibitor. Followed by early maintenance therapy, people started tapering down the CNIs and going on a double drug therapy. So, twofold drug therapy, either CNI plus antimetabolite, CNI plus mTOR inhibitor, or CNI plus steroids. So, depending on the each individual center protocol, people started using these therapies. So the CNI inhibitors basically minimization, conversion, and withdrawal. There are three important things that I'm going to talk about. Minimization means reduce the amount of drug administered, and may be undertaken from time to transplant either de novo or on an elective basis in response to an adverse event. Conversion means tapering doses at any time after transplant until full replacement with an alternative agent, which is achieved and can be undertaken at any time after transplant, usually in response to a CNI related adverse event. And withdrawal means slowly eliminates the drug amount administered early or late after transplant, and CNI avoidance, which substitutes another immunosuppressive drug for the CNI from the outside. So, to summarize, minimization is low dose of CNI. It can be planned de novo or result as a result of an adverse event. Conversion means tapering of CNI dose until eliminated and replaced with other immunosuppressant, usually result of an adverse event. Withdrawal means tapering of CNI dose until eliminated and continuation of other immunosuppressant already in use before withdrawal. This can be planned de novo or result of adverse event. And avoidance means no CNI given, other immunosuppressants are used, can be planned de novo. So, strategies of minimization. So, CNI most commonly reported strategy in the literature implemented by reducing target trough levels of CNI like cyclosporin and tacrolimus. So, there was a 36 randomized controlled trials were reviewed. 22 used cyclosporin, 7 used tacrolimus, and 7 used both, either sequentially or together. Adjuvant agents were mycophenolic acid in 19 and mTOR inhibitor in 14 patients. Induction therapy mostly was IL-2 receptor antagonist, either basiliximab or daclizumab, which is now not available. Early minimization meant less than 6 months post-transplant in 29 studies. There was a high risk of bias in 17 studies, poor reporting on randomization and adherence. So what it showed, that high strength evidence showed improved renal function and reduced biopsy proven acute rejection and graft loss. Moderate strength evidence were low CMV infection rates, no difference in mortality. There was insufficient data regarding the BK virus infection outcomes. The subgroup insight showed that CNI with mycophenolic acid in 19 studies, high strength evidence of improved renal function and reduced biopsy proven acute rejection or graft loss, low strength evidence for no mortality difference. In low dose cyclosporin agents, moderate to high strength evidence for renal benefits and reduced rejection or graft loss, and in low dose tacrolimus, high strength evidence of renal function improvement. So induction agents, as I said, in 19 patients, basiliximab in 16 and 3 in daclizumab, others varied. Early minimization, as I said, less than 6 months, moderate to high strength evidence for biopsy proven acute rejection, graft loss and CMV outcomes. Late minimization, more than 6 months, low strength evidence of higher biopsy proven acute rejection risk, no direct comparison between early versus late strategies. Cyclosporin with mTOR inhibitors, moderate strength evidence for improved renal function without increase in acute rejection. Tacrolimus with mTOR inhibitor, insufficient evidence for conclusions. And basiliximab with CNI minimization with mTOR, moderate strength evidence for renal improvement and reduced graft loss. So Symphony trial, which is Elite Symphony, it was a randomized controlled trial with 1,645 patients. Groups were compared as standard dose cyclosporin, low dose cyclosporin, low dose tacrolimus, and low dose sirolimus. All received MMF steroids, daclizumab induction. Low dose tacrolimus, the best GFR was 65.4 ml per minute, lowest rejection 12.3%, and best graft survival was 96.4%. Sirolimus had highest rejection and adverse events, and dosing of tacrolimus was 0.05 milligram per kg divided into 2 doses, and trough levels was targeted as 3 to 7 nanogram per ml. Sirolimus 9 milligram loading dose reduced to 3 milligram per day, and trough level was targeted at 4 to 8 millinanogram per ml. So if you look at the visual abstract, it shows that out of the 1645 patients done at 83 centers, follow-up of 12 months, they had 3 parameters: low dose cyclosporin, so targeted at standard cyclosporin. Then low dose means targeting trough levels of cyclosporin 50 to 100. Sirolimus targeted at 4 to 8 nanogram, and low dose TAC means 3 to 7 of trough level. Daclizumab was used, and steroid and MMF were common in all the groups. And as I said, in the low dose tacrolimus arm, The graft survival, the primary endpoint was EGFR at 1 year, was highest in TAC level, 65.4 ml per minute. The acute rejection were lowest in TAC levels, 12.3%, and graft survival at 1 year was 94.2%. So to conclude this, a regimen of daclizumab, MMF and steroid in combination of a low dose TAC may be advantageous for renal function, allograft survival, and acute rejection rates as compared with regimens containing daclizumab induction plus either low dose cyclosporin or low dose sirolimus or with standard dose of cyclosporin without induction. Then there was a trial of transform trial which showed that design of more than 2000 kidney transplant patients with a 5-year follow-up. Comparison was everolimus with reduced CNI versus mycophenolic acid plus standard CNI. Everolimus group had a better renal function, fewer viral infections, lower long-term nephrotoxicity, supports early CNI minimization with mTOR inhibitors in selected patients. So this was the transform trial which showed that everolimus with reduced calcineurin inhibitor exposure in renal transplantation. Everolimus intervention, primary outcome was acute rejection with EGFR of less than 50 ml per minute. In everolimus at 1 year, it was 48.2 versus 45.1%, which was not significant. So conclusion was everolimus was non-inferior. This was a non-inferiority trial to mycophenolate and permitted reduced CNI exposure in kidney transplant recipients. This was published in JASN 2018. Then strengths and evidence for all minimization. So if you look at all strengths, if you look at the biopsy proven acute rejection, graft loss, CMV infection, and other opportunistic infection, they all were significantly low in the minimization trial. A patient death had no difference, and BK virus outcome was inconclusive in these trials. If you look at reduced CNI, cyclosporin tacrolimus with mycophenolate, there was no significant, there was minimization associated with reduced rejection, minimization associated graft loss, patient death, no difference, CMV infection, minimization associated with low incidence, BK virus inconclusive, other opportunity infection showed minimization associated with lower incidence, and renal function, minimization associated with a better renal function. When we reduce the cyclosporin with mycophenolate versus standard, again, renal function, minimization associated with improved GFR, biopsy proven acute rejection, minimization associated with reduced risk, graft loss, minimization associated with reduced graft, patient death inconclusive, CMV inconclusive, BK virus inconclusive, other opportunistic infection, lower incidence as compared to other infections. If you look at the standard versus mycophenolic acid, renal function, minimization associated with improved EGFR, biopsy improved associated rejections, graft loss, patient death, CMV, and other opportunistic infection, they were all inconclusive. Then there was this convenient approaches were CNI to mTOR inhibitor conversion. So used for minimization, conversion, and toxicity management in CNI based regimens. Sirolimus conversion, early conversion, 20 to 24 days pre-transplant showed improved renal function, EGFR of 60.9 versus 53.7 ml per minute per 1.73 meter squared, but high discontinuation rates due to side effects of sirolimus. Late conversion, that was 6 to 12 months in patients with EGFR more than 40, showed better renal function and lower malignancy rates. In everolimus conversion, Zeus trial showed early conversion at 4.5 months led to significantly higher EGFR at 24 and 36 months, p-value of less than 0.01. Ascertain trial, where creatinine clearance were more than 50, late conversion after 5.5 years, it showed renal benefit only in patients who had a creatinine clearance of more than 50 ml per minute. Then if you look at CNI concept trial, alternative for patients with CNI nephrotoxicity, cardiovascular risk or intolerant, who are intolerant to CNI, long-term studies, 311 patients, conversion led to higher 7-year graft survival, 78% versus 63%, and better EGFR, 26 versus 20.2 ml per minute, 1.73 meter squared. no significant increase in rejection or mortality. Standard conversion, belatacept 5 milligram per kg IV every 2 weeks for 5 doses, then monthly. CNI reduced by 25 to 60% after each infusion and discontinued by 4 doses. And for toxicity, rapid conversion, belatacept at 10 milligram per kg once, then 5 milligram per kg every 2 weeks for 4 doses, then monthly. And CNI were discontinued by second dose. So this was a phase 3 randomized controlled trial of belatacept versus cyclosporin. 7-year outcome, 43% reduction in death or graft loss with belatacept. Higher EGFR, 26 versus 20.2 ml per minute. Similar rejection and mortality rates. Dosing protocol was belatacept 5 milligram per kg, IV every 2 weeks for 5 doses, then monthly. CNI reduced by 25% after each infusion and discontinued after 4 doses. Safety notes were lower incidence of donor-specific antibodies, but higher risk of PTLD in EBV negative patients. So you have to be cautious in EBV negative recipients. Belatacept have to be used with caution. Then it was a conversion. So we identified 23 studies and assessed the conversion from a CNI to other maintenance immunosuppressive agents. The majority of the studies evaluated conversion from a CNI to an mTOR inhibitor. The remainder assessed the conversion from CNI to azathioprine, MMF, mycophenolate sodium, or belatacept. Moderate to strength evidence suggested modest improvement in renal function in patients converted from CNI to mTOR inhibitor. When the analysis was stratified by the type of CNI, there was a high strength evidence for improvement in renal function amongst those converted to an mTOR from cyclosporin. High strength evidence suggested that conversion to an mTOR inhibitor was associated with lower reported incidence of CMV infection, and low strength evidence suggested that graft loss was similar among patients who converted to azathioprine. Moderate to strength evidence derived from only one study indicated a higher risk of biopsy-proven acute rejection amongst patients converted from cyclosporin to mycophenolate sodium, but was insufficient for other outcomes. So if you look at the comparison, cyclosporin or whether CNI, whether it was cyclosporin or tacrolimus, two mTOR inhibitors, it showed that the renal function, the conversion to mTOR, it was moderate risk evidence, while others, if you look at the rejections, graft loss, patient death, insufficient outcomes, and even BK virus and other infections. If you look at tacrolimus to mTOR, you can see that the best possible thing was reduction in the biopsy-proven acute rejection. Rest all had no effect. If you look at CNI, cyclosporin tacrolimus to mTOR, biopsy-proven rejection and graft loss, patient death, they were all inconclusive. The moderate evidence was renal function when converted to mTOR inhibitor associated with improved renal outcome. This was a comparative effective reviews. Then if you look only at cyclosporin to mTOR inhibitor, the highest renal function was achieved, conversion to mTOR, when it was cyclosporin to mTOR inhibitor. If you look at cyclosporin to azathioprine, biopsy-proven acute rejection, inconclusive, graft loss, no difference, patient death and CMV were inconclusive. Cyclosporin to mycophenolate and formulation can biopsy-proven acute rejection with a higher incidence of biopsy-proven acute rejection. Graft loss was inconclusive, patient death inconclusive, CMV inconclusive. Cyclosporin to mTOR inhibitor, outcome biopsy-proven acute rejection, graft loss, and a patient death. Overall incidence evidence strength was insufficient. So cyclosporin to mTOR did not have much change. When you show cyclosporin or tacrolimus to belatacept, all the strength evidence categories, whether it was graft loss, biopsy-proven acute rejection, the strength was insufficient. So it did not change much. CNI, cyclosporin, or tacrolimus to belatacept, if you look at the strength of evidence, again, either it was biopsy-proven acute rejection, graft loss, patient death, renal function, or cyclomegalovirus infection or other infections, all strengths were insufficient. So withdrawal, high strength evidence suggested that maintenance of MMF after CNI withdrawal was associated with improvement in renal function, but the evidence was inconclusive for the subset of studies using cyclosporin, because cyclosporin is a weaker immunosuppressant as compared to tacrolimus. We all know that. Low strength evidence suggested that early withdrawal was associated with higher risk of graft loss and death, but the evidence was insufficient for biopsy proven acute rejection and renal function. For studies of late withdrawal, MMF was associated with greater risk of biopsy proven acute rejection based on moderate strength evidence. The evidence was insufficient to support any conclusions regarding infections in these subgroups. Then CNI minimization versus withdrawal. Mycophenolate acid-based minimization led to better renal function, although there have been several studies of the potential for CNI-free protocols with mycophenolic acid and steroids. Complete CNI avoidance of withdrawal over the first 3 years has been associated with increased rejection risk and worse outcome in prospective randomized trials. In contrast, CNI withdrawal under MPI and steroids appeared to be safe in long-term maintenance patients beyond 5 years post-transplant and resulted in improved renal function. This observation highlights the decreasing rejection risk over time and provides a good example of a time-dependent minimization strategies. In addition, a recent study suggests that mTOR inhibitors cannot replace CNIs in the initial phase after transplantation due to lower efficacy and a less favorable side effect profile. mTOR inhibitors can replace CNIs at a later stage, for example, 3 to 6 months after transplantation, with significant improvement in renal function despite slightly increased rejection risk. I'll be showing this visual abstract. So if you look at the CNI withdrawal with mycophenolate, the strength evidence showed that biopsy proven acute rejections were lesser in CNI withdrawal with mycophenolate. High evidence cyclosporin withdrawal with mycophenolate, again insufficient data or low significance. Comparison of CNI withdrawal with mycophenolate, again renal function withdrawal associated with improved renal function. Strength of evidence was high. Biopsy proven acute rejection, graft loss and patient death, the incidence of was low. Biopsy proven acute rejection withdrawal associated with high risk of rejections. If you look at late withdrawal of subgroup CNI with mycophenolate, CMV infection and other opportunistic infection, definitely it was insufficient in these groups, but biopsy proven acute rejection, late withdrawal associated with higher risk of rejections, moderate evidence. If you look at a comparison of early withdrawal subgroup CNI with mycophenolate, all the data was insufficient or low evidence strength. CNI withdrawals with mTOR inhibitor, graft loss and patient death, insufficient or low. Biopsy proven acute rejection, moderate strength data. Cyclosporin withdrawal with mTOR inhibitor, all were insufficient or low strength data. CNI withdrawal with insufficient with mTOR inhibitor, insufficient, but biopsy proven acute rejection, 6 RCTs, moderate strength data. If you look at tacrolimus with mTOR inhibitor, biopsy proven acute rejection, moderate risk, withdrawal associated with lesser risk, and relative risk was almost 93%. Comparison, if you look at tacrolimus withdrawal with mTOR inhibitor, it showed moderate risk in biopsy proven acute rejection. Other data was insufficient. So tacrolimus KDIGO 2024 guidelines in CNI management shows that tacrolimus is recommended as the first line agent due to superior graft survival and lower rejection rates. Minimization approach use low dose TAC with target trough levels of 3 to 7 nanogram per ml combined with MMF or azathioprine to maintain immunosuppressive efficacy. Avoid early use of mTOR inhibitors unless renal function is stable. Timing, minimization should ideally begin 3 to 6 months post-transplantation in stable patients. In belatacept conversion, recommended for patients with CNI-induced nephrotoxicity, cardiovascular risk or intolerance, only for EBV seropositive patients due to risk of PTLD. So conversion protocol, as I already showed, belatacept 5 mg per kg IV every 2 weeks for 5 doses, then monthly. CNI tapered and discontinued by 4 doses. mTOR inhibitor conversion considered in patients with stable graft function and low rejection risk. Everolimus or sirolimus will be used with reduced dose of CNI. Monitor for proteinuria and wound healing composition if you're using early. These are the various side effect profiles of tacrolimus versus cyclosporin. Most of them overlap, but if you look at the NODAT, more in tacrolimus, neurotoxicity, more in tacrolimus, hyperkalemia and alopecia, more in tacrolimus. These are the various mechanisms of toxicity: nephrotoxicity, neurotoxicity, hypertension, NODAT, dyslipidemia, infection risk, malignancy in CNIs. How do you manage them? So either you look at the epidemiological profile, you look at the GFRs, you can do cell-free DNAs to look at the outcomes. You should look at the cardiovascular health. So blood pressure target should be less than 130/80. Lipid profile, ECG and echocardiography in high-risk patient. Metabolic monitoring like fasting glucose, blood glucose, HbA1c, weight and BMI, electrolytes, especially hypomagnesemia and hyperkalemia. Neurological symptoms like headache, tremors, confusion, CNI toxicity, seizure, especially related in high dose, and in children, especially Press syndrome is very common in CNI. This thing, hypertension can be managed with ACE or ARBs if not contraindicated. Alternatives can be calcium channel blockers, especially for CNI-induced vasoconstriction. Dyslipidemia, statin should be used. We can use ezetimibe if it's there. Diabetes management should be done with GLP-1 receptor agonist, insulin. Bone health should be maintained with vitamin D and calcium. Bisphosphonates can be used in high-risk patients. For infections, CMV prophylaxis we all give for almost 1 year. For PCP, again, Septran we give for 6 to 12 months. BK virus needs monitoring and reducing of immunosuppression if needed. Thank you very much.
Thank you very much, sir, for excellent presentation. You have nicely discussed the evolving strategies, whether to minimize or move away from CNIs, and how they impact both graft survival and patient safety. So coming to the panel discussion, first question for Vishal Ramteke, sir. Sir, in an era where mTOR inhibitor and belatacept are available, what are the practical considerations when deciding whether to minimize CNI or completely convert away from them?
See, all the studies that have shown conversion to everolimus, they have shown that it's a non-inferior drug. But if de novo, if you start everolimus because of adverse effects of CNI, I mean, they have more toxicities. So if you do a late conversion to everolimus, a certain trial has shown, and if it's done, if you can manage proteinuria, dyslipidemias, then it's a superior drug as compared to CNI. So low dose CNI with mTOR inhibitor definitely has an edge at a late conversion rather than an early conversion.
All right, sir. Vishal Ramteke, sir, your take on this, sir?
Yeah, so Dr. Saxena sir has already nicely summarized and discussed about this topic. I would like to add one important point is, as sir has likely said, late conversion or late addition. The patient selection is the prime most thing what I would consider. So recipients who have those creeping creatinine leading to transplant 1 year post-transplant and biopsy proven evidence of nephrotoxicity without other ongoing rejections, and other complications which are not amenable to dose reduction like the neurotoxicity or the hematological or the metabolic complications. Such are the ideal candidate. I would be not be very comfortable with patients who have higher immunological risk like a recent rejection or an ongoing rejection or a high DSA to be considered for this one. And important thing addition to this is the monitoring part. Once the patient is on mTOR inhibitors with or without CNIs, I would like to frequently monitor for the kidney function, the proteinuria, the cytopenias part, and the trough level also I'd be like to frequently check. So it's never a simple thing. I would say that a carefully selected patient and properly discussed pre-hand would be an ideal candidate for proceeding with this. It's very tempting to have a drug which would improve the renal function, but it comes with the drawbacks also.
Thank you, sir. So individualization for based on the patient profile is a valuable takeaway. Second question for Jigar Shrimali, sir. Sir, how do you balance the long-term nephrotoxicity risk of CNIs with their unmatched efficacy in preventing rejections, particularly in high-risk recipients?
Okay, particularly in high-risk recipient, where for the rejection risk having a history of recent rejection or having high DSA. In this type of patient, obviously, over one side we need to prevent the rejection, and on the other side, we need to have minimization for CNI toxicity. Here, as the study Elite Symphony had very good result that in that situation, low dose tacrolimus with the trough level of 3 to 7 having very good result in the form of graft rejection and preventing biopsy proven acute rejection. Also, the late conversion of standard dose tacrolimus to tacrolimus plus low dose tacrolimus to everolimus, that again can help for that. Now, the important part is for the help of like belatacept would be helpful if with there with EBV seropositive state, that would be helpful. But again, this conversion should be patient specific, and we need to review the cumulative immunosuppression all over with the history of infections like CMV, EBV, and other severe sepsis part before reviewing, because in this high risk patient, in later part, if rejection happens, generally that reversibility is comparatively very less, and then the difficulty arises to further manage the immunosuppression.
Excellent point, sir. As you have rightly said, the art of transplant medicine is to balance the risk benefit equation.
So, Saurabh, I'll just like to share one of my learning that we had.
Yes, sir.
So in
Yes, sir.
2008-9, when steroid free was like in vogue, and Voodle and a lot of trials had come at that time to show steroid free protocols. So we
Yes,
followed
sir.
it. And for 1 year in all ISNs and ISOTs, I was telling about the data about that
Yes, sir.
lesser side effects. 7 days you give it and then you stop it, and you put them on a double drug and all. But by the end of 1 year, we started seeing rejections,
Yes, sir.
and almost 95% patients had to be reintroduced on steroids. So we burnt our hands with that, and I have no qualms in agreeing to it. That sometimes we get overzealous, and as Dr. Vishal also very nicely said, and Dr. Shimali also, immunosuppression is a very thin line, over and
Yes.
under. Both are problem, and we as
Yes.
nephrologists, day in day out, we deal with it, because there is no quantification now with TTV and all these tests coming up. I mean, you can balance some amount of immunosuppression, but at the end of the day, as clinicians, you have to individualize your patient. If you ask for a blanket answer to a blanket question, I don't think any of us will have a blanket answer. So what Dr.
Yeah.
Vishal said was absolutely true. I totally agree with him that individualize your patient, and
Yes.
Dr. Shivali also agreed to that. That individualize your patient, try to minimize the toxicity and to reduce the rate of rejection also, and infections. So that is what the aim of, I think, all the nephrologists who are doing transplant is. Thank you very much.
Rightly said, sir. Excellent points. Thank you very much, sir. So the next talk is by Dr. Manoj Gumbar, sir. It's on basics of tacrolimus and cyclosporin, pharmacokinetics and monitoring. Over to you, sir.
Am I audible?
Yes, sir.
Yes.
Audible. Sir.
Yeah, thank you, panelists, my colleagues and seniors, juniors. Dr. Vishal Sharma has clearly told about the conversion and withdrawal therapy to reduce the nephrotoxicity. But we as nephrologists or solid organ transplant physicians, we all are very comfortable using CNI as one of the immunosuppression. As such, it seems to be very easy actually. We have total 6 immunosuppressions, okay? Cyclosporin, tacrolimus, everolimus, sirolimus, azathioprine, and MMF. Out of this, we have to choose 2. And yet we struggle to optimize the immunosuppression. And in today's date, we know that 95% of the patients are still on CNI when they are discharged. But the problem is with CNIs, especially with tacrolimus, is the narrow therapeutic index. And we know that within the therapeutic window also, some patients will have rejections and nephrotoxicity, and patients who do not achieve the target trough levels at times do not have any rejections. This happens just because the pharmacokinetics intra-patient and inter-patient is large. I'll be reviewing about the pharmacokinetics, pharmacogenetics, and some amount of therapeutic drug monitoring of cyclosporin and tacrolimus. I'll go to the basics. Cyclosporin formulations. We know that we have two types. We had two types. Practically, the young generation will not be knowing about the Sandy They all know about the microemulsion form only. But the difference in the microemulsion form is it is bile independent absorption. The C2 levels are better and the rejection rates are less as compared to the previous Sandy There is available IV form also, which we usually use when we are not able to give the CNIs orally. And we all have used it, but we should remember that it is 1/3 the dose of oral cyclosporin to be used in glass containers, to be transfused in at least 4 to 6 hours, 12 hourly, and the cyclosporin solution remains stable in glass bottle so that whatever you have diluted in the morning, you can use in the evening after 12 hours. Similarly, we have tacrolimus formulations. We have immediate release that we are very familiar with the immediate release, which we use it. Hardly we have used extended release. Maybe the percentage will be very less if I overall see that nephrologists are more comfortable with the immediate release till date. Now, there is also an IV format for tacrolimus, but it is available only if you at few centers and if you only demand as a doctor. There are extended release tacrolimus also. These extended release capsules or tablets are of two forms. One is the Edwograph, which we use it, and the other is Envarsus. I probably do not use, and maybe it's not available here also. But there is a difference between the two extended release capsules. I'll be covering this later on also. Regarding IV tacrolimus, I will just again say you have to use it in glass bottle, and for IV tacrolimus, you have to infuse over 24 hours only. And again, the diluted form of tacrolimus remains stable for 24 hours. Now, next is how to administer. First is cyclosporin. Obviously, you have to give at a 12-hour interval, consistent time of the day, and with consistent relation to meals, so as to decrease the intra-individual blood variations. Non-modified form, that is Sandimune, to be mixed with milk, chocolate, or orange juice at room temperature. And modified can be mixed with water, orange juice, or apple juice. Both cyclosporin adhere to plastic, and they should not be used in plastic cup or even stirred with plastic utensils. If a dose of cyclosporin is missed, we should instruct the patient to take it as soon as possible, ideally within 4 hours, and we should always tell him if you have missed the dose and you have forgotten it, not to double the dose in the next dose. Regarding tacrolimus, the immediate release should be taken at a consistent time of the day, preferably on empty stomach. The extended release tablets should be taken at the same time of the day, preferably in the morning, not to crush, chew, or divide the tablets. If an immediate release tab is missed, to be taken it as soon as possible, ideally within 4 hours. And if extended release tab dose is missed, to be taken it as soon as possible, ideally within 15 hours. Now regarding pharmacokinetics of both. Both drugs are poorly soluble, highly lipophilic, and they are able to absorb through cellular membranes. Bioavailability of both drugs is around 25%, and tacrolimus has a wide variation from 5 to 90%. Wow. There are two actual mechanisms of metabolism. One is at the intestinal level and one is at the liver level. In the gut, tacrolimus is subjected to, again, two barriers. Within the intestinal lumen or intestinal cell also, there are two barriers. One is the P-glycoprotein proteins and CYP3 enzyme within the intestinal cell. The P-glycoprotein works as an efflux transporter and plays a major role in the pharmacokinetics of tacrolimus and cyclosporine. This efflux pump, it drags out back into the intestinal lumen the absorbed tacrolimus or cyclosporine, and it regulates tacrolimus access to CYP3A. Now, this repeated uptake and efflux of tacrolimus results in extensive first-pass metabolism as the drug is continuously exposed to CY3P enzymes in intestinal wall. That means the CYP3A enzymes are never saturated. That means whatever the drug is available, okay, only very few amount of the drug practically is able to bypass this intestinal absorption of both mechanisms. Next is this synergistic effect of CYP3A and P-glycoprotein can significantly influence the absorption of TAC. Only the parent drug that escapes intestinal metabolism enters hepatic portal system. Different distribution of CYP3 and GPA, PGP protein within the intestine. The CYP3 expression decreases more distally. This is very, very important point to remember, that the CYP3 expression decreases distally while the PGP concentration increases distally. But in spite of PGP concentration increasing distally, the absorption of tacrolimus mostly occurs in the distal intestine. And that is the reason when the intestinal transit time is reduced, actually, the TAC concentration in the distal intestine, it increases, which happens in diarrhea. And that is the reason in diarrhea, the tacrolimus concentration is more in patients. Now, regarding the peak concentration, it reaches to peak at 30 to 60 minutes in most of the patients. The elimination half-life is 12.1 hours. And in transplant patient, it ranges between 3.5 to 40 hours. Now, the absorbed tacrolimus is bound to 99% to erythrocytes. And only the dissociated form enters the lymphatic system and has a major immunosuppressive effect. That is the reason we always order whole blood concentration level and not plasma level of tacrolimus. Tacrolimus is highly protein bounded, that is with albumin or acid glycoprotein. Plasma volume of distribution is much lower than the whole blood volume of distribution. Now, as previously I have said that there are three different formats available for tacrolimus. One is the immediate release, which we use rampantly. The other is Advagraph, and the third one is LCP-TAC. The mechanism is the mechanism of both extended release and LCP-TAC is different. The advantage with LCP-TAC is that the Tmax is increased, the Cmax is reduced. We all know that the Cmax, that is C2 levels, do not correlate with rejection in tacrolimus, but the C2 max level does correlate with nephrotoxicity. And that is the reason at times you can use LCP-TAC for reduction of nephrotoxicity in patients whom we know that this can be a cause of nephrotoxicity. Now, the difference between, I'll discuss about the liver metabolism. in liver is the main site for TAC metabolism. CYP3A is the predominant enzyme for tacrolimus, while CYP3A4 also contributes to metabolism of tacrolimus. Cyclosporin is primarily metabolized by CYP3A4. Tacrolimus undergoes hydroxylation, demethylation, and oxidation reactions, producing first and second generation metabolites. There are at least 8 metabolites of tacrolimus, but the major one is 13O demethylation is the major one. And it has an activity of around 10% of original tacrolimus. While 31O demethyl tacrolimus has an immunosuppressive activity comparable with tacrolimus. 95% of the TAC is eliminated mainly as metabolites via the biliary route, while only 2% of the parent drug is excreted in the urine unchanged. So we have two mechanisms. One is the intestinal mechanism, one is the liver metabolism for tacrolimus, and another additional elimination route is there in which the commensal gut bacteria, they convert TAC into a 15-fold less potent metabolite M1. Now, regarding the pharmacokinetics of cyclosporin, peak concentration is achieved at around 90 minutes. There are 25 metabolites are formed, and the cyclosporin metabolites are mainly excreted in the bile, with only 3% of the drug undergoing renal elimination. Now, this graph shows the difference between the originals, the previous Sandimune, and the current microemulsion form of cyclosporin. We know that C2 level does correlate with rejection as far as cyclosporin is concerned. The major reason why microemulsion form of cyclosporin is better than the previous Sandimune is because the C2 levels are higher in microemulsion form as compared to the Sandimune molecule. Now, this slide shows that there are various factors responsible for the CNI exposure to the patient. These are age, the recipient donor, and others. I'll be discussing one individually. First of all, again, it is the difference between the formulation, whether it is a immediate release, granulosate formation, that is Advagraph, or LCP tag, that is Envarsus. Advagraph, it is in granulate formation extended release tacrolimus. That means the drug is available for absorption only in the distal part of the intestine. The proximal part of the intestine where the major CYP3A is available is not able to metabolize this tacrolimus. Next is LCP tag. It has a melt dose technique. This technique is breaking down the particles into the smaller units. That means the absorbable part of the tacrolimus is available only in the distal intestine. The advantage of distal release of the tacrolimus is that the distal part of the intestine has very low CYP3A levels. And that is the reason with longer acting tacrolimus, there are lower intraday fluctuations, prolonged Tmax to reach to the Cmax level. Now there is a difference between the ER tag, that is Advagraph, as overall in Advagraph, there is no difference in terms of exposure, Cmax, Tmax, or fluctuations as compared to immediate release. But when you compare with the LCP tag, it is almost that the Cmax is reduced by 17%. And when you have to change the conversion from one form to another, then with LCP tag, you have to reduce by 30%. And if you have to convert from Advagraph to Envarsus, you have to reduce it by 36%. That is the difference between everolimus, extended release, and LCP tab. More important is that, as previously I also said, the C2 max level in tacrolimus do have a role in tremors and nephrotoxicity of tab. Now, next is diurnal variation. We have always used in immediate release in part in 12 hours, but we usually get the levels in the morning. But actually, there is a better absorption of tacrolimus in the morning hours. In the evening hours, because of the slow, the gastric emptying rate is reduced in the evening, and more drug for catabolism is available in the proximal intestine. So practically, there is the area under the curve for evening dose is less by 15 to 35%. These studies were done in ENVAR's longer acting. But even in case of immediate release capsules also, the evening dose absorption of the drug is lesser as compared to the morning dose. And that is the reason if you use extended release tacrolimus, always to be used in the morning hours. Next is age. We all know that pediatric patients require higher dose of tacrolimus to reach to a certain trough levels. And at times we have used even in fact 8 hourly we have to give tacrolimus to reach to that trough levels. The reason is that the liver size of the patient is larger as compared to their body weight. And they have a very active CYP3A levels. More that means pediatric patients are mostly fast metabolizers, and that is the reason we will have to use more of tacrolimus to reach to a certain trough levels. Similarly, elderly patients, the problem is they are having too much of comorbidities, and that is the reason they are using too many drugs. And we all know that there are certain drug interactions which are detrimental to tacrolimus. Either they increase the dose or reduce the TAC levels. But the mechanism why elderly patients require less tacrolimus is that there is a poor or the splanchnic flow or the hepatic blood flow is reduced. They have a higher body weight, higher fat content. The percentage of fat is more. We must have realized this that obese patients usually require less tacrolimus to reach to a tacrolimus levels as compared to the fat, because obese patients, the CYP3A levels are inactive. There is a difference in the gastric pH of elderly patients and adults also. Tacrolimus CNIs are better absorbed with acidic pH. Change in pH can lead to changing from acidic to alkaline can reduce the absorption. Again, most of the elderly patients are slow metabolizers, and these are all the reasons why the renal susceptibility to tacrolimus increases with kidney age. Another factor is ethnicity. Africans and Americans require higher tacrolimus dose as compared to Asians or Indians. This is because the frequency of CYP3A star 1 is 73%. That means, and CYP3A 5 star 1 is a fast metabolizer. So the levels tacrolimus required, the dose of the tacrolimus required to reach to a certain level will be much higher as compared to Asians. Next is hepatic dysfunction. Tacrolimus clearance reduces up to 30% in hepatic dysfunction, and this can lead to raised tacrolimus levels. Diarrhea. We all know that, and we always teach our students that never do a tacrolimus levels when the patient is having diarrhea, because of increased tacrolimus levels will get it. But the fact it is not a pseudo increase, actually it is true increase, because the absorption area shifts from proximal to distal intestine, and where the distal intestine, now we know that the CYP3A levels are, enzyme levels are low. In diarrhea, there's a hemoconcentration also, and there's a damage to the intestine and inflammation. These all leads to increased drug permeability. And this infection and inflammation again have a negatively effect on the CYP3 and PGP expression. That means the activity of this will be lowered. Next is, we have discussed about the gastric pH. Now regarding the motility, it depends upon, again, the gastric motility rate is lower, the tacrolimus concentration increases in the distal intestine and the absorption increases. We always instruct our patients to take tacrolimus on empty stomach, either not to take anything before 1 hour of the drug, or if you have taken the food, if the patient has taken the food, at least after 2 hours of taking food, the tacrolimus should be used, because we know that the peak concentration reduces by 50 to 75% if tacrolimus is taken just immediately after food. Especially the fat content is very, very important. More the fat content, less is the tacrolimus absorption. And it is not only the peak concentration, it is the area under the curve is also reduced by 40 up to 40%. Now again, we are very familiar with this, that tacrolimus is bound to albumin or glycoprotein, and only the free part is available as immunosuppression effect. Now, when there is a low albumin, obviously the free unbound tacrolimus levels will be high. And if you measure the whole blood concentration levels, practically the C0 levels will be similar. It will be within the therapeutic range, but unbound fraction will increase, and that is the reason with a patient of low albumin, it is exposed to tacrolimus nephrotoxicity and other side effects. Cyclosporin, on the other part, is not effective with the low albumin as compared to tacrolimus. Hematocrit again has a similar effect as albumin. We all know tacrolimus is bound to more than 90%, in fact 99% to the erythrocytes. Now, if there is a patient has anemia, obviously the plasma fraction of the tacrolimus will increase, and patient will have potential to have nephrotoxicity despite normal C0 levels. For juniors, again, I'll tell you for DNB students that we always prescribe whole trough levels whenever we ask you that. But in case of anemia, obviously the free level will increase and patient will have toxicities. Again, in case of polycythemia, the total C0 may be therapeutic, but active drug may be low, which is very important to remember, because the cases of post-transplant polycythemia are very well known to us. That these patients, we consider that the patient is the kidney is optimally functioning, but we should always remember that the free part of the tacrolimus, the unbound fraction, is lower in these patients. Next is sex. Female patients require higher tacrolimus dose because the CYP3A activity is dependent upon the estrogen levels. And that is the reason in pregnant women also, the estrogen released increases the CYP3A4 activity, and at the same time, but we have a low albumin and anemia. So maybe in pregnant women, theoretically, obviously, the TAC levels will reduce, but the unbound fraction, because of hypoalbuminemia and anemia, will increase. So no doubt the levels, C0 levels will reduce, but hardly there is a need to actually increase the tacrolimus levels in pregnancy. Another is exposure of tacrolimus to the fetus. No doubt tacrolimus can cross the placenta barrier, but fortunately here the GP efflux mechanism is available, which pushes back the tacrolimus on the mother side in the placenta. So overall, no doubt about it, as far as first trimester, second trimester, or third trimester is concerned, there is as far as C0 levels, there is a need to increase the tacrolimus, but obviously it should be guided and need not necessarily every pregnancy will require an increase in tacrolimus levels because of the fact of hypoalbuminemia and anemia. Obviously, if the patient is not having any of those, then obviously you'll have to increase the tacrolimus dose. Similarly, in case of breastfeeding, tacrolimus only 0.23% maternal dose is detected in the breast milk, while in case of cyclosporin is almost like 1%. So with tacrolimus, we usually allow the mother to feed the baby, while in case of cyclosporin, we always instruct it is to be a cautious use, or it is better to avoid cyclosporin, or it is the word to avoid the breastfeeding to the baby. Now, we all remember that grapefruit juice. With grapefruit juice, we should not use CNIs because grapefruit has an element that is known as furanocoumarins, which are potent inhibitors of CYP3A4 enzyme, and that is the reason patients should be instructed not to take it with grapefruit juice. Obviously, we should remember there is a difference between grapes and grapefruit. These two are different fruits. We all know about the drug interactions. I'll not go into the detail, but now the time has come to realize which drug is acting on which part. Is it acting on CYP3A level or CYP3A, or is it acting on glycoproteins? Supposedly voriconazole. Voriconazole acts on CYP3A. We usually avoid giving voriconazole along with tacrolimus because we know that up to 9 times the level can increase. But here, if you have to use voriconazole along with tacrolimus, better to use an extended release tablet, which is less dependent upon CYP3 for its absorption. The time after transplantation. Initially, we all know that methylprednisolone will increase the level of steroids. So the first level, which we usually do on methylprednisolone, do not reduce your tacrolimus dose. The moment you convert from IV methylprednisolone to steroids, your levels are going to go down because steroids induce CYP3A4 activity and methylprednisolone increases the levels of tacrolimus. Again, we have to keep in mind the hematocrit and albumin levels, which increase after post-transplantation. I'll not go into the details, preferred levels, which have been very well covered by Dr. Vishal Saxena, sorry. Next is, I'll go to pharmacogenetics. This is very important to understand why there is a difference in the pharmacokinetics of these patients. Now, first is CYP3A enzyme. For tacrolimus, this is the major route of metabolism. Now, you have to remember CYP3A star 1. If it is 1 is there, it is considered as wild type. Wild type means they are fast metabolizers. Wild type means they are expressors. That means these patients will rapidly metabolize the tacrolimus, and the dose of tacrolimus to achieve a certain trough levels will be higher in these patients. Similarly, if the patients are homozygous for CYP3A5 star 3, that means these patients are non-expressors or slow metabolizers. Now, these patients will require lower tacrolimus levels to achieve the target trough levels. In studies, it has been found that if there is a homozygous for CYP3A5 star 3/3 genotype, then tacrolimus dose required is almost like 50% lower as compared to wild type allele. Now, CYP3A5 genes are available both in hepatic and renal, and both determine the tacrolimus exposure to the kidneys. Now, there was a funny thing happening actually. I have done a simultaneous pancreas and kidney, simultaneous liver and kidney transplant done 1 month back, and I had got routinely I'd go for this genotypes. My genotype was poor metabolizer, but my levels were not supporting this after simultaneous liver and kidney transplantation. I was not able to understand, but in review of literature, preparing for this lecture, I got the answer. This is because the liver now was of donor type. That means practically in these patients, it was two mechanisms that go taking into the intestinal part was of recipient CYP3A5 levels, while the liver part was of donor. I was not knowing the CYP3A level of the donor this time. And that is the reason, expectedly, in spite of having poor metabolizers, the levels were not high in my patient. Next is CYP3A4. Cyclosporin is predominantly being catabolized by CYP3A4, but in tacrolimus, it has a role, but little as compared to CYP3A5 enzyme. Now, particularly if you have CYP3A4 star 22, that means this patient will require lower tacrolimus as compared to the wild type. Wild type is CYP3A4 star 1. It is almost like 33% reduction in mean tacrolimus levels at first year. If if the patient is having this allele, and most important part is that it is independent of CYP3A5 status. The ABCD1 codes for the PGP or the efflux proteins, but the available data of these single nucleotide on tacrolimus pharmacokinetics is inconsistent. So I have not gone into this detail. Now, if you see what is the effect of CYP3A5, it is almost like 17% alone is responsible CYP3A for this. If you combine RBC count, albumin, and CYP3 expression, it is 40%. And if you combine all the 44 gene variants, only 70% is understanding is available as far as pharmacokinetics of tacrolimus is concerned. Now, there are usually because of cost constraints, we usually do only CYP3A5 levels. But there are, on research basis, it has been found that if you have CYP3A star 6 or CYP3A5 star 7, practically the CYP3A is non-functional in these patients, and patient will require very low levels of tacrolimus to reach the desired trough levels. So, at least I do it, I'm comfortable, and I have made my students also comfortable regarding this. Even in live-related as well as cadaveric patients, I do this. In advance, I do and monitor this. Supposedly, now, just because it costs actually, the almost cost is around doing one CYP3A5 level in one patient is around 5,000 to 6,000. Now, if you do not want to spend these 6,000, you can do one thing. When the steroid levels have reduced, your dose of steroids have reduced to less than 20 milligram, which usually we do it around 1 month. You calculate the C by D ratio. C by D ratio is the total the level of tacrolimus divided by the dose of tacrolimus in 24 hours. Now, if this ratio is less than 1.05, then this patient is definitely a fast metabolizer. Again, with fast metabolizer, you can consider switch to extended release tacrolimus or other drugs. You can start the conversion for this. Good. Next is therapeutic drug monitoring. We all know that with tacrolimus, the C2 levels they do not correlate with the rejection, and the C2 levels correlate with nephrotoxicity. But in case of cyclosporine, yes, definitely the C2 levels correlate with the rejection. In tacrolimus, we do it 12 hours in case of immediate release, and in case of extended release, we do a 24-hour trough constant levels. We have to remember that with cyclosporine and tacrolimus, steady state concentration is achieved after 4 to 6 doses. And that is the reason whenever you start tacrolimus or cyclosporine or make a change in the dose, not to do tacrolimus levels before 3 to 5 days. Now again, if you have got the CYP3A genotype known to you, and if it is a slow metabolizer, do not do it before 5 to 7 days. Do not change the levels earlier than this. Do not reduce it further because this is a slow metabolizer. Your drug is still not metabolized. Your previous dose is still having some effect on the current levels even after 5 days. Now, how and to measure? We usually do it after discharge. We do it once a week for first 1 month, once in 2 weeks for the next 3 months, once a month for the next 6 months, and then, but if your patient is stable, low risk patient, even monitors are done, even in the first year, they are done once in 3 months. I have already have discussed about the C2 levels, importance of C2 levels in cyclosporine. As far as tacrolimus, the C2 level does not correlate. In fact, the C3 or C4 level does correlate with the area under the curve 0 to 12 hours. But a new strategy can be done, that is limited sampling strategy. That is, you take you withdraw twice. One is at C0 and one is at, you withdraw the blood between 2 and 4. This definitely correlates better with the area under the curve. And we all know that area under the curve is the best method for drug monitoring. But because of the cost and the number of samples, we usually don't do it. And usually with cyclosporine also, usually we use C0 levels. There are certain centers which use C2 levels monitoring in the initial period. Again, reminding that whole blood trough concentration to be done. Second is better to be done in the morning and evening hours. We should know that there is a difference between the morning absorption and evening trough levels. And that is the reason these trough levels, just because of the difference in the absorption in the morning hours and the evening hours, that they can differ. We usually have a habit of, supposing the dose is 1 or 0.5, we usually give 1 in the morning and 0.5 in the evening. But I think it should be reversed. If the lower the dose is used, okay, it should be in the morning you choose lower value and higher value should be given in the evening time. With tacrolimus, there is a intra-individual variation is around 20 to 60%, and even in the same patient with the same dose, there is a variation of around 10 to 40%. Regarding the methods, immunoassays are widely used. Previous immunoassays, they had cross-reactivity with the metabolites, but the newer ones, that is the CNI and the QMS methods, which do not interfere with the metabolites, are used. But the liquid chromatography method, especially the LCMS, that is liquid chromatography, mass spectroscopy remains the gold standard. These are the types of immunoassays available in the market, but make sure wherever you get the tacrolimus levels, the CMIA word should come or the QMS word should be there. And because these are the things, these are the methods which do not interact or count the metabolites in the okay. And now these newer CMIs, they can have the capacity to detect as low as 2 to 4 nanogram per ml, and the cross reactivity is very little. LCMS remains the gold standard, but it too has its limitation. The limitation is of high cost, and they are useful only in high load centers because calibration is very important and you require 24 hours laboratory support to run the LCMS method. Now, the take home message is yes, you should do genotyping of the tacrolimus. I think you should do it, but overall, there is no general recommendation, but it does help to optimize the immunosuppression individually. Again, there is no difference in the incidence of acute rejection in expressors and non-expressors, but we are comfortable in the initial period once the tacrolimus levels comes in the range of that levels which we want actually. Usually it is, we keep it right now with ATG, 8 to 10, we are happy with that. But unless and until that 8 to 10 or 8 to 12 level comes, so does not come, we are worried about rejections. Next is newer immunosuppression. The CMIA and the QMS are reasonably accurate, easy to use, and suitable for routine monitoring. Thank you. Thanks a lot. Namaste.
Thank you very much, sir, for that very comprehensive overview. It was very insightful. Coming to the panel questions, question for Nishit Mohanty, sir. Sir, despite decades of use, variability of tech exposure remains a challenge. In your opinion, how close are we to personalizing the CNI dosing using pharmacogenomics or real-time monitoring?
Okay. Good evening, all. Now,
Yeah, good evening, sir.
Good
Yes, sir. Yes, sir. Audible, sir.
Dr. Manoj has already covered everything. I have little to say. Actually, I have 25 years of experience using tacrolimus, and really it is very difficult drug to monitor and treat. So, for personalizing the drug, I think the TDM is the best thing as far as possible, as far as now it is concerned, because the pharmacogenetics is not that widely used. There is little studies in India. There is only one study I could find. It was done by Dr. Srinivas from Kerala. So they have recommended that it is useful, but there should be comparative study. Your RCT should be there. And another study there in your Slovenia, they are telling that pharmacokinetic testing is definitely better, and it should be combined with the TDM. So if you ask me today, I will prefer for precision medicine. This therapeutic monitoring is best suitable because it involves the metabolism, it involves the absorption, distribution of the drug, and we can monitor it continuously. And probably it can be done anywhere in India now, and can be monitored. So therapeutic drug monitoring of tacrolimus is definitely the way now at present for monitoring tacrolimus level. And Dr. Manoj already covered everything, and pharmacokinetics, pharmacodynamics, and all the distribution, everything. So we'll see pharmacogenetics is good. It is upcoming, but it will not say you which patient will give how much tacrolimus will give. It will not give that information. Only that will give information that this particular person it will require how much of tacrolimus, but it will not help even the monitoring of the drug. So as far as monitoring of the drug is concerned, definitely TDM is the way of doing managing tacrolimus or day-to-day practice.
Thank you very much for insightful perspective, sir. So the third and last talk is on the biopsy findings in CNI toxicity by Radhika Patil, ma'am. Over to you, ma'am.
Good evening, dear all, respected seniors. Thank you, ISOT, for giving me this opportunity. I will be quickly discussing on biopsy findings of CNI toxicity. To start with the case, 54 years old male, known case of CKD on maintenance hemodialysis for 2 years. Patient underwent a live-related renal transplant a month ago, donor being the elder brother. Patient is on triple immunosuppression. On examination, he is hypertensive. Worsening RFTs with serum creatinine being raised to 4.5 milligrams per deciliter. Renal biopsy was done to rule out rejection. So this is low power view of renal biopsy HND stained section showing moderate tubular injury with denudation and flattening of the lining epithelium along with loss of the brush border. There is no evidence of significant mononuclear tubulitis or interstitial inflammation. So T cell mediated rejection is ruled out. There is no evidence of any vacuolizations also. The glomeruli, the upper glomerulus appears unremarkable. The lower glomerulus, even at this magnification, is showing some eosinophilic material occluding the afferent arteriole. And the artery is showing intimal fibrosis. Maybe it is donor related. On further magnification, the HND stain section shows a glomerulus with no evidence of increase in cellularity, but or glomerulitis, but this material, eosinophilic fibrillar material, occluding the afferent arteriole or the hilar arteriole, and which is PS positive also. On meson trichrome stain, it is fusionophilic, fibrillar or granular in appearance, and there is some mesangiolisis also. So this was fibrin thrombus, occluding the hilar arteriole or afferent arteriole. C4D was negative, which was done by IHC. So there was no any history of native kidney disease showing any HOS or TMA. So the diagnosis was given as de novo TMA, thrombotic microangiopathy. There is associated moderate acute tubular injury. No definite evidence of rejection seen in the biopsy study. On follow-up, tacrolimus level found to be raised to 18 nanograms per ml. So the final diagnosis was TMA due to TAC toxicity. So CNI causing structural toxicity to almost every compartment of the kidney is involved, but the terms like acute and chronic are inaccurate since CNI arteriolopathy and glomerulopathy can develop within days to few weeks. So we use the term early and late changes, and histological features are not the diagnostic, they are just suggestive of CNI toxicity. So in glomeruli, early minor changes, there is endothelial cell injury, necrosis. The major changes, fibrin thrombi, what we have seen in our case, and the late major changes, there will be splitting of the GBM forming tram track appearance, and that will be largely irreversible. In tubules, the early minor changes will be isometric vacuolizations, giant mitochondria will be seen on electron microscopy, and the late minor changes, microcalcification. Arterioles, early minor changes, there is smooth muscle cell swelling or ballooning, that is CNI arteriolopathy. Early major changes, TMA, and late major or minor changes like medial or adventitial hyaline deposits, that is characteristic classical CNI arteriolopathy, and intimal fibrosis. The striped interstitial fibrosis and FSGS are also seen as secondary changes. So let's start with the compartment wise. Glomeruli, as we have seen, the CNI, they are causing the vasoconstriction and releasing of endothelin and causing ischemia, and then endothelial injury also, which will trigger the coagulation cascade and formation of this fibrin thrombi. So when this is seen, also we can see the collapsing glomerulopathy. This is silver stained section showing segmental collapse of the tuft with hypertrophy and hyperplasia of the overlying podocytes with this protein resorption droplets. Other changes like FSGS with segmental hyalinosis. This is attached to Bowman capsule. There is no prominence of overlying podocytes and there is arteriolar hyalinosis. Also, we get to see there, this is silver stained section and there is arteriolar hyalinosis of this afferent arteriole. The hyalinosis is silver negative and there is ischemic wrinkling and thickening of the GBM. Also, there is segmental sclerosis. So, transplant glomerulopathy, that is late change seen in CNI toxic glomerulopathy, that is nothing but the GBM duplication. There is splitting of the GBM and mesangial cell interposition forming tram track appearance, and it is known as transplant glomerulopathy. So on immunofluorescence microscopy, when CNI toxicity is there, what changes we see? They are not specific, like IgM and C3c staining is seen in arterioles with hyalinosis, fibrinogen staining in thrombi in small arteries, arterioles, or the glomeruli which were showing the changes by TMA. So when we see transplant glomerulopathy, what other DDs we should think of? So there is active or chronic chronic active or chronic antibody mediated rejection we should think of. In that, concurrent MVI, that is microvascular inflammation, will be there, that is glomerulitis and peritubular capillaritis. So the glomerulitis is seen in this. The glomerular capillary lumina are not patent. They are infiltrated by these mononuclear cells. There is duplication of the GBM. So this was a case of chronic active ABMR. And also the C4D was showing strong linear continuous positivity along the walls of the peritubular capillaries and along the GBM. Also DSA will be positive. So other DD will be membranoproliferative glomerulonephritis. In that, we will see pronounced glomerular hypercellularity, proliferative changes, and mesangial cell interposition. Sometimes crescents are also seen. Here we will silver and PAS will show the highlight the GBM. So here we will appreciate there is duplication of the GBM and also mesangial cell interposition. So there is mesangial and endocapillary hypercellularity also. So when we on IF, it will definitely show immune complex type deposits. Those are granular deposits of immunoglobulins and complement. And also we have to look carefully. There will be outer smooth contour for this capillary walls. So that will indicate the deposits are subendothelial rather than subepithelial. On electron microscopy, there will be splitting of the GBM and neomembrane formation. To remember, O, that is outer is the original one and inner is the neomembrane formation. In the tubules, we will see early changes as vacuolizations. So the vacuolizations, they are isometric. The tubular epithelial cells show isometric cytoplasmic vacuolizations and they are due to enlarged smooth endoplasmic reticulum. Similar changes are also seen when the patient is given mannitol or IVIG. So that has to be ruled out and it has to be differentiated from other vacuolizations. These are coarse, irregular, clear vacuolizations of hypokalemic nephropathy. So other change, microcalcifications, calcium phosphate deposits are seen. In the interstitium, there will be striped fibrosis, that is alternate bands of fibrosis are seen. The green one are showing the non-atrophic tubules and there is some tubular injury with loss of brush border. The red ones are the atrophic tubules and there is fibrosis. So these are the atrophic tubules are the ones which are not having much tubular lumina. It is reduced and there is there is wrinkling and thickening of the tubular basement membrane, which is highlighted by this PAS stain. So this is due to chronic ischemia in watershed zones of medullary rays due to hyaline arteriosclerosis and direct tubular toxicity. So this is again the same striped interstitial fibrosis. The green ones are the non-fibrosed areas, non-atrophic tubules, and these are the fibrosed areas are the red ones. So in the vessels, there will be a CNI arteriolopathy, that is smooth muscle cell ballooning. The smooth muscle cell ballooning is seen, and also the smooth muscle cell hyalinosis. So this is the case of diabetic nephropathy. This glomerulus is showing prominent silver positive mesangial widening, focally exceeding the diameter of adjacent capillary lumina and forming an early KW nodular lesion. These changes also we have to see to differentiate and look at this. Yes, basement membrane thickening is also there, and this afferent arteriole in diabetes, afferent and efferent arteriolar hyalinosis is seen, but the intimal layer is involved for hyalinosis. Here, look carefully, it is intimal, and here it is medial, and slowly the adventitia will also be involved. The smooth muscle cells are, the nuclei are showing the smooth muscle cell nuclei. So this will give us a pearl-like or beaded appearance and nodular arteriolar hyalinosis in CNI toxicity, where medial smooth muscle cell is involved. And this lesion cannot be considered specific, but it is included in the Banff lesion scores. The no typical lesions of CNI related arteriolopathy, no hyalinosis is 0. One is replacement of degenerated smooth muscle cells by hyaline deposits in only one arteriole without circumferential involvement. More than one arteriole is 2 without circumferential involvement, and even if one with circumferential involvement, it becomes AH3. So what other differentials we should think when we see the TMA in vessels? So rule out any history of TMA or HUS, native kidney disease. ABMR, as we have seen, microvascular inflammation, and C4D and DSA being positive. For arteriolopathy, the clinical history, KW lesions or capsular drop lesions, hyalinosis lesions of diabetes. In hypertension, concurrent intimal fibroelastosis or intimal fibrosis will be seen. And both diabetes and hypertension, they cause intimal or subendothelial arteriolar hyaline deposits. But in CNI, there will be medial smooth muscle cell involved. Pre-existing donor disease, if the 0-hour implantation biopsy is done, then only we can rule out that. And lastly, the chronic vascular rejection typically affects the arteries, but not the afferent arterioles. So for revising glomeruli, we have to look for fibrin thrombi, collapsing glomerulopathy, FSGS, TG, global glomerulosclerosis at the last. For the tubules, then isometric vacuolization, microcalcifications, interstitium stridulofibrosis, vessels, CNI arteriolopathy, arteriolar hyalinosis, and TMA. Thank you. Thank you.
Thank you very much, ma'am, for such a comprehensive presentation. And the way you summarized both the classical lesions, they were very crisp and informative. Thank you, ma'am. So coming to the panel discussion, first question is for Swanlata, madam. Madam, the classic arteriolar hyalinosis and stripe fibrosis are considered the hallmarks of CNI toxicity. So how specific are these findings in real-world biopsy settings?
Good evening, everybody. I think Radhika sort of started off the talk, and very early in the talk, she said that none of these changes is specific for CNI toxicity. So that is to be remembered when nephrologists read our reports, that none of these changes is specific. It is only in the clinical context and sometimes just a combination of changes. If you have a change involving the vascular compartment and say the glomerular compartment or vascular and interstitial. For example, if you get peripheral nodular hyalinosis and you get, say, isometric vacuoles or tubular calcification. And in the clinical context, we can just suspect a CNI toxicity. I, for one, am very reluctant to put a definitive diagnosis of CNI toxicity because CNIs, as we have listened to in the first two talks, are like the backbone of immunosuppression. And so for us to just stop that in a single sentence saying that it is CNI toxicity can be very hazardous. So we just discuss with the nephrologist and we could put like a suspicion of CNI toxicity, but definitely a definite diagnosis of CNI toxicity is very difficult on the graft, and I, for one, will be very reluctant to just give that. The other point I would like to say is that uh, when you see even thrombi, like the first case, her case, the TAC level was very high, so it was sort of certain. But definitely, if you just see an isolated thrombus like TMA in the allograft, very, very difficult to say, yes, it is due to CNI toxicity. And there are quite a lot of papers saying that those patients who have even a CNI-induced TMA actually have a defect of the complement pathway. It's like a second trigger, as it were. So I think that needs to be kept in mind also when we say that it is, when we say TMA, usually lists all the causes if we are not able to find out the cause. And very often, the other thing is in our population, many of them don't have the native kidney disease diagnosed. And my feeling is that many of them are recurrent TMAs. Young males, hypertensives, have some complement disorders, come with end-stage renal disease, not biopsied, and very early post-transplant, they get a TMA. My hunch is that most of those patients have, maybe it's triggered off by CNIs, but they probably causing the TMA. So these were the 2 points that I wanted to say, and thank you very much for the invitation.
Thank you, ma'am. That was very clinically relevant answer. And we all should be cautious against the over-attributing chronic lesions to CNIs. That's a reminder for all clinicians. Second question is for Vishali, ma'am. Ma'am, with newer tools like molecular diagnostics and digital pathology, do you see a future where we can detect CNI toxicity, nephrotoxicity earlier than by histology alone?
Yes, a very good evening to all. And thank you, ISOT, for this invitation. As we just discussed, the histological features of CNI toxicity are not very specific. And yes, we try to look for other alternative methods which can give us a specific clue whether it is CNI toxicity or not. And we know gradually molecular diagnostics are being incorporated in transplant pathology also. We know in recent 2022 BAMF update, the gene expression profile, which is validated profile, is being incorporated in the diagnosis of ABMR. So on the same, in the same context, we hope in future we have some validated gene expression or molecular profile related to CNI toxicity, which can help us. And there are some research and some studies which have studied few molecular profiles in cases of CNI toxicity, and there are certain pathways. For example, in CNI toxicity, the pathways of epithelial mesenchymal transition, the pathway of platelet activation, the endothelial dysfunction, these are upregulated as compared to immune regulated pathways. And we can say that these very markers, they can help us in specific diagnosis of CNI toxicity, for early diagnosis of CNI toxicity, and for targeted therapies also. For example, there are some subcellular pathways like oxidative phosphorylation, fatty acid metabolism. These pinpoint pathways, if we know they are altered, we can offer some targeted therapies also. And last but not the least, if we have to go in a non-invasive way, there are some urinary biomarkers also which can help us to know early and specifically that yes, this is CNI toxicity. And coming to the use of digital pathology and AI, these two things are gradually coming up in transplant pathology, and we know that BAMF is trying to incorporate AI-based algorithms, especially in grading of chronicity changes. We hope AI algorithms are in future will come up, and we can pinpoint some minor and subtle changes pertaining to CNI toxicity. Thank you.
Thank you. Thank you very much, ma'am. Thank you for linking the emerging technologies with real-world applicability. Thank you very much.
Can I just say one more
Yes,
point?
yes.
Just a small
Yes,
point
ma'am.
on this arteriolar hyalinosis. You know, at least there's one nice paper by Professor Colvin which says that in an allograft biopsy done, like, say, anytime after 3 months to 3 years post-transplant, if you don't see arteriolar hyalinosis, then you must start thinking whether the patient has enough CNIs. You know, whether the level of CNI has been enough. And in fact, if there's no hyalinosis, the chances of rejection are more. You know, so I think it's better to think that way than thinking that if there is arteriolar hyalinosis, it's a CNI toxicity. You know, so I thought that was because we see it all the time in allograft, and we should not be putting a label of CNI toxicity on that. So I thought that was a very nice paper which was worth mentioning.
That was excellent point, ma'am. Thank you for that insight. So with that, we come to close of today's session. And on behalf of ISOT, I sincerely thank our distinguished speakers and panelists for their time, expertise, and wisdom. A big thank you to all our participants, especially residents and young professionals who continue to make this platform so vibrant. And thank you all once again for joining us. We look forward seeing you in the next ISOT EduConnect session. Thank you very much.
Thank you.
Thank you. Thank you, sir. Thank you. Thank you, madam.